Welcome all to this Gyneacology session on gestational trophoblastic neoplasias. My name is Baljeet Kaur and I am one of the consultant histopathologists, the regional lead for trophoblastic diseases at Charing Cross Hospital in London. In today's talk, we would be talking about WHO classification of gestational trophoblastic diseases, spectrum of gestational trophoblastic neoplasias, talking in details about the trophoblastic tumors and very briefly about moles and trophoblastic tumor-like lesions and the importance of right diagnosis in this setting. Many of you in the audience would have seen this latest 5th edition of the WHO Blue Book on female genital tract tumors, where the table or the classification of GTT has slightly changed. In addition to the previous categories, we now have the category of mixed trophoblastic tumor, which has appeared under gestational trophoblastic neoplasms in the latest edition. This entity we have known existed but was never there before in the WHO Blue Books, and also a better recognition has been achieved by placental site nodules and atypical placental site nodules, and the criteria for diagnosis have become more defined. So going through this classification, these are tumor-like lesions, molar pregnancies, and various types of tumors, amongst which coriocarcinoma is the most common tumor, and the others include placental cytrophobatic tumor, epithelioid trophoblastic tumor, and as I said earlier, the mixed trophoblastic tumor. Talking now about the spectrum of GTD. In the spectrum of gestational trophoblastic diseases, we have pre-malignant conditions which can give rise to malignant neoplasms. The most common among these is complete moles, which have the highest risk of progressing into persistent trophoblastic disease or neoplasias, and 15 to 20% of these molar pregnancies give rise to gestational trophoblastic tumors. Partial moles can give rise to these tumors in 0.5 to 1% of the cases and therefore have much lower risk. There has been a small amount of risk also associated with abortions or normal pregnancies, and many of these kind of pregnancies can give rise to predominantly placental cytrophobatic tumors but also to coriocarcinoma. In addition to above, we now know that 10 to 15% of atypical placental site nodules can progress and give rise to PSTTs and ETTs. In order to understand the tumors better, let's first talk about the various types of trophoblasts that can be seen in a normal pregnancy. Trophoblasts can be of basically two types. Villus trophoblasts, these are the ones which are outlining the chorionic villi. These can be cytotrophoblasts, the outer layer of syncytial trophoblast, or the intermediate type trophoblasts, which are seen in trophoblastic columns, and they are the ones which attach to the decidua and then later on form the extravillous type of trophoblast, giving rise to the implantation site within the decidua. In addition, the extravillous trophoblast can be seen in the poles which are not forming the placenta, and here they degenerate and form what is known as chorion levae type trophoblast. The understanding of type of trophoblast will now form the basics for understanding what are the different types of lesions that can arise from each type of trophoblast. As you can see in the chart here, which has been borrowed from the latest WHO Blue Book, the chorionic villus type trophoblast can give rise to hydatiform moles and also various kind of atypical villus lesions. The intermediate type trophoblast, however, are responsible, as you can see from here. These are responsible for forming most of the tumors. So gestational coriocarcinomas arise from villus intermediate trophoblast, whereas PSTT and ETT arise from extravillus trophoblast. A mixed trophoblastic tumor can contain a combination of these type of trophoblasts. As this lecture deals mainly with gestational trophoblastic neoplasia, we would be talking in very brief about the molar pregnancies. We all know that in a normal pregnancy, one sperm fuses with an egg, giving rise to a normal fetus, which has one contribution from mother and one from dad. In molar pregnancies, and especially in complete herediform mole, there is no copy of DNA from the mother. There is fusion of one sperm or two sperms with a blighted ovum, resulting in two copies of DNA from father. This extra chromosomal material from father without the regulatory material from mother leads to exuberant proliferation of placental tissue within the uterus without the formation of the baby. As a result, in the usual classic kind of complete moles, there is large villi with cistern formation and exuberant trophoblastic proliferation in addition to karyorrhexis, which is the most common diagnostic clue for identifying these cases morphologically. There is increasing recognition among pathologists of an entity called as early complete moles, and this is usually clinically missed and also missed on radiology because there is not enough trophoblastic proliferation or hydrops within the placental tissue as yet, and these are detected very early on pregnancy, usually before 10 weeks of usually within 10 weeks of gestation. The chorionic villi can be very small in these kind of moles and can be missed. However, there is abundant karyorectic debris. In addition, there are what is called as very hypercellular stroma, and also there are abnormal extravillous trophoblasts, which can be a clue in absence of trophoblastic hyperplasia. It is very important to perform P57 immunocytochemistry on this on these cases, and what one can see is complete absence of staining within cytotrophoblast and syncytial trophoblast, whereas your internal control of extravillous trophoblast is always positive in cases of both classic complete mole and in early complete moles. One very rare type of complete mole, which we are increasingly recognizing now, is the diploid biparental molar pregnancies, and these are different in the sense that the genetic constitution of these moles is exactly similar to what we see in normal pregnancies, as there is fusion of one sperm with one ovum. However, the maternal copy over here is silenced and it does not express. Silencing of maternal chromosomes in this type of complete mole occurs due to mutation in either NLRP7 or KHD3CL gene within the maternal chromosomes. These account for 95% of the known causes of this type of mole. However, less than 5% of the cases, we do not know what other genes could be involved. The importance of recognizing this genetic disorder is that these patients continue to have recurrent diploid complete herediform moles, and as a result it is nearly impossible for them to conceive normally, and egg donation is the only choice which has helped these patients. Coming to partial moles, these are triploides. And as you can see from the diagram here, that it is a result of two chromosomal contributions or two contributions from father and one contribution from mother, resulting in what we call as diandric monogynic triploidy. This results in formation of a fetus which is abnormal and would be miscarried, but a very grossly abnormal placenta. As a result, the placental tissue, when we put it down the microscope, we have two populations of chorionic villi. Some are large with cistern formation, whereas others are small and sclerotic. And there is focal lace-like trophoblastic hyperplasia, in addition to trophoblastic pseudo-inclusions, stromal sclerosis, hydrops, and cistern formation. Various other conditions can mimic a complete or partial mole, and the new term coined in the latest WHO for these lesions are abnormal non-molar villus lesions. The various conditions which can come under this group are hydropic abortions, chromosomal trisomy syndromes, digonic triploid gestations, placental mesenchymal dysplasias, and rarely the twin conceptus which can mimic the moles. The importance of correct diagnosis, as we have seen earlier, is there is a higher risk of persistent trophoblastic disease or progression into trophoblastic neoplasms with complete mole versus partial mole. And the latest protocol we use at Charing Cross Hospital, the follow-up for complete mole is much longer, whereas that of partial mole is shorter. And that is the latest protocol which is used in our center. A large percentage of cases which are registered with us at the Trophoblastic Disease Center undergo remission, and these are 80 to 85%, whereas 15 to 20% of these patients progress to persistent trophoblastic disease and into trophoblastic neoplasms requiring treatment and/or chemotherapy. One such patient presented to us with a previous history of CHM and markedly high HCG levels of 85,000, and imaging of this lady who was 38 years old showed lung metastasis. We received a hysterectomy specimen from her, and this showed a hemorrhagic lesion deep within the myometrium. The cavity of the uterus was normal. On histology, this lesion showed very abnormal dilated chorionic villus with exuberant trophoblastic hyperplasia around it. There were various other villi seen deep within the myometrium and plugging the vessels around this area, and this is therefore a case of invasive hydatiform mole. The wedge tissue from her lung showed a cavity which was hemorrhagic and had very abnormal distended chorionic villi with trophoblastic hyperplasia, showing characteristic features of complete mole. The blood vessels were seen plugged with these abnormal villi and the trophoblastic hyperplasia, and this was therefore a molar metastasis to lung from that invasive hydatiform mole. We are going to talk about gestational trophoblastic neoplasms, and the most common gestational trophoblastic tumor which we know about is coriocarcinoma. Coriocarcinoma arises in 1 in 50,000 pregnancies. Most of these women are of reproductive age group. It was initially reported in the literature that this tumor is more common after abnormal pregnancies, especially after CHM. However, with the introduction of screening following detection of hydatiform mole, proportion of cases that are occurring following the term non-molar pregnancies have now increased. These tumors usually present with vaginal bleeding and marked elevation of HCG, and rarely they may present with metastatic disease, which has been reported to lung, liver, kidney, spleen, and GI tract. Macroscopically, these are usually hemorrhagic and necrotic tumors, and down the microscope they show characteristic bilaminar population which is composed of intimate admixture of syncytial trophoblast and cytotrophoblast, in addition to large numbers of intermediate trophoblast. The tumor usually occurs in confluent sheets and nests and is a very destructive lesion. At times, much of the tumor is necrotic, and there could be only very small viable rim of tumor cells which can be seen. It is mitotically very active and very rapidly proliferative. So we can see numerous mitosis down the microscope. No single immunohistochemical marker is sensitive or specific for diagnosis of trophoblastic tumors, and therefore we normally use a panel of immunomarkers for diagnosis of these tumors. What we use more commonly in our institute is cytokeratin 18 along with GATA3, which is an upcoming marker used for trophoblastic differentiation. In addition, we would put up a panel of HPL, Melcam, or what we call a CD146, MUC4, P63, and HCG. Very few cells within this tumor can also show positivity for p63, PLAP, and beta-catenin. The differential diagnosis which arise when we are looking these tumors down the microscope, could it be a very early pregnancy with cytotrophoblastic shell, which can be reminiscent to coriocarcinoma, but again the clue lies in your history and also finding of very early chorionic villi, and these cytotrophoblastic shells are non-invasive. Or could it be a complete heritiform mole with exuberant atypical trophoblastic proliferation, which we can see, and sampling more tissue can help because you could see those chorionic villi emerging. The common differentials which are really important in these settings is distinguishing these tumors from non-gestational germ cell tumors or coriocarcinomatous differentiation in a somatic malignancy. We are all aware of a list of germ cell tumors which can produce high quantities of HCG along with various somatic malignancies showing trophoblastic differentiation, which can be confused with coriocarcinomas morphologically. The diagnosis of these rests on molecular genotyping, and it is very important to understand that a gestational tumor will have a genome that will reflect that of pregnancy in which it arose, by which we mean that it will have one set of DNA which is foreign to the patient's DNA, which has come from the father, and this is paternal DNA. Whereas any non-gestational tumors which we normally see will have the genome that is completely reflective of that of the host. That is, it will have DNA, all of the DNA material is from the patient in these tumors. In clinical practice, it is extremely important that we get this diagnosis of gestational versus non-gestational coriocarcinoma right, because as you can see from this chart, the prognosis of these patients and the chemotherapy which is given to these patients is completely different. In addition, the pattern of their spread and how the disease metastasizes is also critical for management of these cases. In addition to uterine coriocarcinomas, we can have ectopic coriocarcinomas, for which the most common site is fallopian tube, but it can also occur rarely in ovary, broad ligament, and in peritoneal cavity. Here you see an example of coriocarcinoma within fallopian tube, and it is very important to submit the entire tube in these scenarios and make sure that there are no chorionic villi present. This tumor is hemorrhagic with an intimated mixture of intermediate, sensitio, and cytotrophoblast. This slide shows the characteristic immunopanel with the diffuse positivity for cytokeratins, GATA3, HCG, and HPL. In addition, there are few cells which are positive for MCAM and MUC4, whereas it is negative for p63. The Ki67 proliferation index is extremely high in these tumors. Coming now to placental cytrophobatic tumors. These tumors were first described by Kerman in 1976. It was initially thought to be a benign lesion, but later on recognized as a unique malignant trophoblastic tumor occurring in reproductive age group females. Most of the time, these patients present with amenorrhea, bleeding abnormalities, enlarged uterus, and they may be it may be thought that they are actually pregnant. HCG levels in these patients can range from 5 to 26,000 international unit, and they are detectable in 80% of the cases. However, in 20% of the cases, they may be extremely low to be detected. Two-thirds of these cases follow a full-term pregnancy, and there could be a latency ranging from few months to 20 years between the pregnancy and the time the tumor is diagnosed. However, the median interval is between 12 to 18 months. It is an extremely rare trophoblastic tumor and represents 0.25 to 5% of all the tumor category. Macroscopically, these tumors can be well to poorly circumscribed lesions, which can range in size from 1 to 2 centimeters to large masses that can completely replace the uterus. Rarely, these tumors can originate from extrauterine sites, including fallopian tubes and ovaries. Cut surface of these tumors can often be mistaken as fibroids, and they can appear very soft, yellow, and without any hemorrhage. On microscopic examination, PSTT is characterized by a diffuse and infiltrative growth pattern of monomorphic intermediate cells, which are arranged in sheets and cords, and these are seen to typically infiltrate myometrium and split the myometrial fibers while they move along, replacing the uterine wall. There can be extensive fibrinoid necrosis and areas resembling implantation site within this tumor. Mitotic activity is typically low. It ranges from 2 to 4 per 10 high bar field. And there is usually, it is quite monomorphic, but at times you can see multinucleate syncytial trophoblast-like cells within this tumor, and in addition, necrosis can be seen. Again, we will be putting up the whole panel of immunocytochemical markers as we have described earlier, but this time the tumor would be seen to be diffusely positive for HPL and MELCAN, much more than that was seen in coriocarcinoma. HCG positivity can be focal, and there are only very rare cells that can be positive for P63 and PLAP. In view of its growth pattern, this tumor can mimic a metastatic carcinoma or a primary leiomyosarcoma, epithelioid leiomyosarcoma of the uterus. It can also mimic melanoma, mesothelioma, or PCOMA, and the other common differential in curettings could be exaggerated placental site reaction. The characteristic immunocytochemistry for PSTT is shown in this figure with the name of the markers down here. And here is a table for differentiating placental site trophoblastic tumor from exaggerated placental site reaction in a curettage specimen. Please remember that Chi67 and mitosis are very helpful, and if you see chorionic villi, it is unlikely to be a PSTT. This is an exaggerated placental site reaction. Next, we come to one of the rare form of gestational trophoblastic tumors, which accounts for only 0.8 to 2.3% of all of the trophoblastic tumors, and this is epithelioid trophoblastic tumor, or ETT. The tumor again occurs predominantly in reproductive age group females, but has been reported even in postmenopausal women. Most of these patients they have an antecedent pregnancy that has been reported either as term pregnancy or a spontaneous abortion, and it is preceded by herediform moles in only 16% of the cases. The patient have an HCG level which is mild to moderately elevated, and most of the time this is less than 2,500 international units per liter. In cases with antecedent pregnancy, the latency can range from 1 to 18 years, but on average, the latency is 6 years. This tumor is derived from intermediate trophoblast of chorion leve type, and around 25% of these tumors metastasize, and it can lead to death in 10% of these cases. So, on macro, these tumors appear as solid or cystic nodules with areas of necrosis and hemorrhage. It is seen with equal frequency in lower uterine segment and cervix, and as within the uterine cavity. And the tumors can have a range of sizes between 5 to 50 millimeter. The pattern of growth over here in these tumors is much more nested, carcinoma-like, with areas of these calcification and also the degeneration, very pink material, eosinophilic material between the tumor cells. Most of this tumor is composed of very monomorphic cells which have eosinophilic to clear cytoplasm. They can form these areas which can look like keratin pearls and can mimic squamous cell carcinoma. A few of these polymorphic cells can be seen between this monomorphic tumor, but essentially it's a very bland looking tumor with an extremely low mitotic activity. On immunocytochemistry, we will put up our characteristic panel, but this time the tumor cells would be diffusely positive for p63 and PLAP, and there would be rare cells which could show positivity with HCl, HCG, and CAM. Ki67 in these tumors ranges from 10 to 25%, and the most common differential diagnoses are listed here, among which, as I said, squamous cell carcinoma of cervix, which also occur in young females, is the most common differential, which needs to be excluded. As you will see in the clinical lectures, that the causative pregnancy is really important in both PSTT and ETT to predict the prognosis. This is not always the antecedent pregnancy, and if this pregnancy is before 4 years, the prognosis of these patients is much worse than those where the causative pregnancy is within 4 years of diagnosis of the tumor. The new entry into WHO Blue Book in 2020 is that of a mixed trophoblastic tumor, which is the rarest form of the trophoblastic neoplasm. The most common mixture is usually that of coriocarcinoma and ETT, and less commonly we can see a mixture of coriocarcinoma and PSTT. Least common tumor is composed of all 3 elements, and only 2 of these cases have been reported in literature as yet. A quick run through one of our cases of mixed trophoblastic tumor. So here you can see a hemorrhagic lesion lined by very pleomorphic cells. And on higher part, this has the characteristic features of coriocarcinoma. But the edges of this tumor have these very nested arrangement with central area of this pink material looking like keratinization. And you can see these elements of ETT lying next door to this coriocarcinoma. So this is a mixed trophoblastic tumor, coriocarcinoma, and ETT phenotype. Finishing up with our lost entities of placental site nodules and atypical placental site nodules. Placental site nodules usually originate from uninvoluted placental sites, and it is a benign counterpart of epithelioid trophoblastic tumor, as both of these lesions originate from chorion leve type intermediate trophoblast. These nodules can be an incidental finding seen in endocervical or uterine curettings from young reproductive age group females, or these females may have presented with abnormal bleeding and endometrial curettings were obtained to ascertain the cause of these bleeding. Within the endometrial tissue, as you can see here, these can be seen as a very hyalinized nodule sitting next to the endometrium, and on closer inspection these are composed of intermediate type trophoblast. Many of these appear degenerate and shrunken, and looking at these in closer power, there is mild to moderate pleomorphism which is expected in trophoblastic cells. However, no necrosis or no mitotic activity is seen at the low part. And if we do a Ki67 proliferation index, these lesions show less than 5% proliferation, and the lesional cells are positive for P63. Coming to atypical placental site nodules, which have been recently recognized as a distinct entity in the new WHO Blue Book. These lesions are now recognized to show features intermediate between those of typical placental site nodule and epithelioid trophoblastic tumors, and the criteria which are not definitive as yet, but which are helpful in making these diagnoses include large size of these nodules, which can range from 5 to 10 millimeter, increased cellularity, marked nuclear atypia, increased mitotic activity, and a Ki-67 proliferation index of more than 5%. It is shown now, as we have seen in the first slide, that APSN have an association with GTT in 15% of the cases. So here's an example of atypical placental site nodule. In contrast to the previously seen slides, these are much more pleomorphic and more viable looking trophoblasts. There is an area of central necrosis. Prominent mitotic activity can be seen. Even if we see 1 to 2 mitosis on H&E, that is considered as important. And these lesions have a Ki-67 proliferation index of more than 5%. I think I can leave the audience to read through this slide. And finally, I would like to thank the organizing committee for inviting me for this talk. Here are some of the resources which I would like to show, which could be helpful in further strengthening the knowledge on gestational trophoblastic diseases. Many thanks for your attention. I would be happy to take the questions in the designated time. Thank you. Bye-bye.